My name is Tom Huizinga. Yes, hello. My name is Tom Huizinga and it is past 2, so I think we should actually start. Before I start, I would like to thank Gordon for organizing this wonderful meeting, Gordon. I see that you're just looking around, but we are very, very grateful for you. So I am here to this Keuzeversuch, the Glycome switch, which is a project of Gordon, Manfred, Salome, René Toes, and myself. And it is about rheumatoid arthritis, that there is a critical glycine switch which determines the pathogenicity of RA. So not everybody is a rheumatologist in the audience. Yeah, it is thinking. So what is rheumatoid arthritis? It's a disease of the joints, and it basically leads to dysfunction of the joint and destruction of the joint. Then it is a disease which is very common. It's about 1% of the world population has this disease. It is hallmarked by autoantibodies, and that's actually the focus of my talk. So there are two antibodies. One is rheumatoid factor, that is a very old antibody, and the other antibody is the so-called anti-citrulated peptide antibodies. What actually happens that arginine is converted to a citrulline. Tolerance to the citrulline is actually broken, and then you make these antibodies. These antibodies are a hallmark of disease, and also if you look at joint destruction, which is on the y-axis, time on the x-axis, then you see the patients without these antibodies have much less joint destruction than the patients with these antibodies. So it is an antibody which is associated with severity of a disease. And we, René Toes and myself and the group at Leiden, discovered, and Manfred, discovered something very special, because what you can actually see if you isolate these antibodies and you look at the size of the antibodies, and then you see the fractions over here. A normal IgG is 150 kD, but these antibodies are a little bit bigger. So it's very strange. All antibodies are 150 kD, and these antibodies are a little bit bigger. And then, of course, the question, why are they actually bigger? And then if you separate the antibodies, and here you see again size, here you see IgG ACPA, and here you see normal IgG, and you can see that they are a little bit bigger. Then why are they bigger? Is it the Fc part? Is it the antigen binding part? Then you see the Fc part here, and it's exactly the same, but you can see that the antigen binding part is actually a bit bigger. So if you then look at the antigen binding side over here, you can see here is the part over here, it is IgG ACPA, and you can see that this is a little bit bigger than this actually. So that's an important thing. Then are all ACPAs actually bigger? And that's because why are they bigger? They are bigger because they are glycosylated. So the protein backbone is exactly the same, but they have a glycosylation on the antigen binding side. Then you can calculate, is that common? If you look in normal IgG, it's only 20% of IgG who has a glycosylation, and if you look in ACPAs, it is 100%. And this is all work also done by Elise, who's also here. So then you can say, why is it? Is it because there is somatic hypermutation, so the glycosylation sites are introduced, or is there some other process which is actually doing that? Well, it is actually that they are introduced, and the glycan site is something which is not germline and coded, so you need T-cell help to actually introduce that. And then if you actually look at a number of mutations here on the y-axis, and you look at tetanus and you look at ACPA, you see that this is much higher. And what we also saw, that it is not a random thing. So the B cells continues to hypermutate till they have this glycan site, and they can attach a glycan to the FAP. So the hypothesis of this whole story, which you're gonna hear for the coming afternoon, is that this site determines that the B cells actually survive over there. So this is a critical component of the B cell survival to actually have this, but that's a hypothesis. So where are we now? I need to go here then. I think, yeah, so I basically said that to you, so you actually need T cell help to actually to have somatic hypermutation and introduce the glycosides over time. So when is it actually happening? Well, if you go from healthy to a phase where you don't have inflammation yet, but you have only arthralgia, only a little bit of pain in your joint, and during this phase, the glycosylation is introduced, and then here it is not altering anymore. So we really feel that you need the T cell help here. We have some data of that, because if you look in healthy people with ACPA, there's absolutely no HLA association over there. But the HLA association is over here. So we feel that it's because you need the T cells to introduce the somatic hypermutation, that you can attach the glycan to the antigen binding site. And the hypothesis is that that gives a survival to the B cell that you have these antibodies. I'm a little bit confused what is happening. So that is basically over here, there. So then, is it also relevant? Is it predictive of disease? So we are very lucky to collaborate with Hani El Kabalabi, who lives in Canada, and he has this beautiful cohort of people. And what you have in those people, you have actually healthy people, you have healthy people who are ACPA positive, and you have RA patients which are also ACPA positive over time. So this was a nice cohort for us to follow them prospectively to see if these patients who have ACPA develop RA over time. So that's what we actually did. So that you can see here. And if you look at the patients over time, you have patients who do not transition to RA over time. So you can see that it is over here. You have patients who transition to RA over time. You can see it is here. And if you then look at the phi-domain glycosylation of ACPAs, you can see that this is higher than this. If you make the slide a little bit different, you can see it over here. Here you have the time from transitioning to RA. Here you have time. This is patients with low phi-domain glycosylation, and you can see there's no transition to RA over time. And this is patients with high phi-domain glycosylation, and you can see it over here. So what I showed you, this phi-domain glycosylation is also predictive of disease development over time. So then, do we have more data for that? Yes, we actually have, and I can show you quite many data over time. And that's what you see over here. But again, here again, healthy people who are ACPA positive, the phi-domain glycosylation is quite low. Here there is people from Japan, ACPA positive, healthy people. Okay. And you can see it's also quite low over here. Then here you have arthralgia, so no arthritis yet, but joint pain. And you see it is actually higher. And here you have an RA cohort, and you see it is even higher over here. So predictive that the more phi-domain glycosylation you have in your ACPA, the further you are on in development of disease over time. So it's basically here. Do we have more data? Yes, we have much more data. So I'm going to show it over here. So again, the central picture of this is healthy people. This is pre-symptomatic people. This is patients with joint pain. This is RA. So you can see what is going on over here. Then, of course, we have all kinds of cohorts. We have 4 months, 8 months, 12 months. And sometimes you are very lucky. You have sustained drug-free remission over time. So there is no arthritis anymore. So that is also important to say. So let's look here, what you can see. Here you have, again, the phi-domain glycosylation on the y-axis. Here you have all the cohorts, and basically what I showed you already, this is going higher, and then it is the same, and then it's a little bit higher, but then if it flares, there is again a lot of phi-domain glycosylation over time. So all this epidemiological data, it's only epidemiology, are suggestive that this is a very important thing over time. I'm supposed to go forward and then here. And then you can say, okay, if it's so important, this, because you're developers, can you use your current drugs? Is this something of the B cell, or is it inflammation or something like that? So we actually wanted to test that, because if we could inhibit all inflammation, could we all inhibit V-domain glycosylation over time? And the answer to that is no, because what you see here, you see the correlation between CRP, which is a measurement of inflammation in your whole body, and you see the ACPA IgG. Here you see V-domain glycosylation. Here you see low CRP, and here you see a high CRP. Well, what is crystal clear from this data, it is not that high CRP is actually driving this. So this is an inflammation-independent thing in a B cell. That's an important issue, what you should know. Okay, what have the patient data, looking from the patient is, I think what you can see that high levels, even before disease, are predictive of disease, so that is important. Then you see towards disease onset, you have more and more and more V-domain glycosylation. There's after disease onset, it is a very stable trait. Then there is a slight decrease in, but you can see it was a really slight increase. And it is not so that it is all an inflammation-dependent thing. So it is something which is happening inside the B cells. So that's an important thing. So of course, do we have certain clones there, or many clones? I will not talk much, because René Toes, who will talk after me, he will give you all the mass spec data and show exactly what it is like. So then, why are this V-domain glycosylation, is it so important? Is it because of the B cell, or is it because of the antibodies? I think that's an important thing, or is it both? So what we say, could it be that this V-domain glycosylation is important for the B cells to actually survive and make this pathogenic thing, so the pathogenic B cells, and then do you get disease over time? So if we understand this biology, it may be able that we can cure. So that is enormously important to actually understand. So let's look over here, and this important thing, what is going to happen over there. And then I'm not so used to things. So is this the important thing what we can actually do? If that's the case, if the V-domain glycosylation is so important, it should give a signal to the B cell. So in order to study that, we made cells, and you can actually see we have a wild type in it, with a human ACPA in it with sugar, and exactly the same cell. So this is a cell line, this is a Ramos cell line, where you have exactly the same antibody, but with sugar and without the sugar. So if it's true that this is so important, because this sugar does something to the B cell, then we should be able to show that. So we compare this cell to this cell, and the only difference is the sugar over here. And I'm going to show you all kinds of different readouts, but the bottom line is this sugar is doing something to you. So let's look over here. So what did we do here? So we have exactly the same cells with sugar, without sugar, and then we basically cross-ligand either by antigen or by a FAP fragment. And then what you see, this is a calcium flux. Let me see over here, and what you can clearly see, this red line is different than this blue line over here. So the signal transduction is actually different. And I can also show it in better data. So if you look at the calcium fluxes, so the blue line is with the sugar, this is without the sugar, and you can see this is actually not the same. This is not the same as this. So it is doing something. That's an important thing. And here you see sick phosphorylation, and you can see exactly the same, whether you give antigen or you give a FAP fragment. You can see that the blue line, the blue column is different from the red column over here. So showing that if you trigger this Ramos cell line with a human ACPA in it, with sugar or without the sugar, that both the calcium fluxes and the sick phosphorylation is actually different. So that's an important issue to see. So then you can also look at antigen uptake, again, with sugar, without sugar. And here you see if you start there, the antigen uptake is exactly the same. Yeah, we always have enormous troubles having something in the cool, because at 4 degrees you can see there is already a difference over here. but if you heat the cells up to normal temperatures, you can see there is a clear difference over here. So antigen uptake is also different over here. So I think I showed you an important thing. This V-domain glycosylation is important, both with regard to internalization, with regard to glycosyl fluxes, phosphorylation. So it is really important over here. So our hypothesis, that's a hypothesis, that this V-domain glycosylation is doing something, and I don't know whether it's cyclic 10 or whatever it is, but there is some receptor over here. And if you can identify that, and that is what Gordon, Salome, Manfred, René, and myself will hope to do, if we can identify this, then we could intervene with it and we could cure rheumatoid arthritis over time. And then you can say this is all very much focused on the B cells. Maybe the B cells are important, but are the antibodies also important? Is it really the antibodies? Is the V-domain glycosylation doing something to the antibodies? Well, of course, we actually tested that. Again, the same antibodies with sugar and without sugar. And of course, you can also treat it with enzymes to remove sugar as a control over that. It's all on the slide. But let me talk it to you. What you see here is binding. Here you see a concentration. In red, you see the binding of the non-glycosylated. In blue, of the glycosylated. And you can see it is not the same. So the V-domain glycosylation is also affecting the binding to citylated antigens. We have different citylated antigens. This is CCP2, CCP1. This is a very high affinity antigen. But clearly you can see that the red line is different than the blue line over time. This is antigens. So here we have all kinds of citylated peptides. Here we have all kinds of citylated proteins. And what you basically can see, it is not always the case, but in most cases, it's also affecting antigen binding. So, even more, can it also affect complement activation? It made sense, the talks we heard yesterday, I think Gester already said that you can, for complement activation, you need hexamerization. And you can easily think that if there is some sugar here, that this hexamerization is not as easy over time. So I'm not gonna spoil your fun because Lisa will talk about you, and I think the hypothesis is that it would affect complement activation because it has such a big influence, but you will hear it from Lisa actually later. So V-domain glycosylations on ACPA is a double-edged thing. It affects antigen binding, which you can see here, and I showed it to you, and it affects B cell function. Then you say, okay, you are a doctor. What is more important? Is it the B cell or is it the antigen binding? I think it's the B cell. And I'm just going to show you why I think that, but the data are not super good, but I just would like to share the data with you. So what you can do if you look at the disease activity over time, here is the disease activity. It is actually high and then it is actually lower. Or you have patients who start very high and then go very low and then they flare. Or you have patients who have always active disease. So my hypothesis would be, if those antibodies are so important, I think the antibody titers should be high here and low here, because the patient is doing fine here and the patient is doing horrible here. So if the antibodies would be important, I would expect that the antibodies would be high here and low here. Well, you can see it here. There is nothing happening to the titers of the antibodies. Again, if I have patients who have high disease, low disease, high disease, I would expect antibody titers high, low, high. Well, you can see this is absolutely not the case over time. And if you have always active disease, you can see that the antibodies are also active. So basically, there is no good correlation between antibody titers and disease activity. So that's why I think it is not so likely that the antibodies are so important over time. Then we actually tested that in all kinds of assays and patient cohorts, and you are not doctors, so I'm not going to go in exact detail over this, but I think that antibody titers are not so important. So what is my hypothesis at this moment? The effect of the V-domain glycosylation is important on the B cells, and because it is important on the B cells, it gives a survival signal to the B cells, and that's why you have these autoreactive B cells. And I have all kind of data, I have no time to show that, but I really feel that the ACPA specific autoreactive B cells are the killers in disease pathogenesis of the patients. So what I hope to do, in the glycan switch, is we know that this is the way it actually works. We would like to understand what the V-domain glycosylation is doing here. We hope to intervene here in this process, and then we hope to stop the disease over time. And if we do that, I think then the glycan switch team will be invited to one of the Nordic capitals, let's put it that way. So that's why we do it. Okay, having said that, there is much more data to come, and I just would like to give a small introduction over here. I think Lee, you will talk, I think, after René too, so after that, so she will talk about this kind of things. And then the bottom line, of course, René and myself have been doing this for the last 15 years, but there have been many people actually working with it, and we are enormously happy that we can do that in this glycan switch with Salome, Gordon, and Manfred to go on with our research. Thank you very much for your attention. And I guess we have time for some questions. Gester.
Thank you very much, Tom. In one of the first slides that you showed the ACPA profiles that are a little bit bigger, there was this dimer, also larger molecular fraction as well. So what is that? Is that dimers of IgG or IgA or something else? Remafactor?
We have spent quite some time looking into that, and we don't. The bottom line, I think I know exactly what you mean. You mean this big, is it right?
Yes, exactly.
And this big? Yeah, I don't know. That's the bottom line. René, you want to say? No, but we of course we thought, is there something attached to the ACPA or something? So we felt it super cool, but we spent quite some time also with laying the trial on it, and the bottom line is we were not able to identify what's exactly. Salome. Oh, sorry, you can also first. I'm just used to do ladies first, actually.
Beautiful talk, Tom. I have a question. Is there any evidence of potential correlations between the ACPA VDG levels with other biomarkers that in combination could be correlated with disease prediction as a way of improving the performance, predictive performance of the ACPA VDG? I was thinking, for example, on microbiome, because microbiome has been also associated with RA infection, etc. Any correlation?
There is a small correlation where you go from here to here with CRP. So there is something. We have tested many elements in the microbiome. I can never pronounce the three culprits we have, but we just had it with Michael. The bottom line is that we don't have good data on that. We have some suggestions that there might be, but no good data.
Thank you very much. My question is, with regards to, could we test whether it is in fact causative, these B cells, with that? Could we introduce them in a mouse model? Could we deplete them?
Salome will do that in the glycan switch, but I have some data for you on that as well, because I was afraid that I always get the feedback from René too that I give too much data, so I didn't want to do that. But these are ACPA this is patients who are in sustained drug-free remission over time. So if you look at this kind of patients, and you look at their B cells, you can see if there's something special with the B cells. And the point is that is the case, because maybe the best way to show it is this. So we look at people who are not converted from clinical suspected Croatia or ACPA positive compared to people who are converting. So that's and basically what you see, that you see higher levels of CD80, higher levels of CD86, but the cell division marker is exactly the same. So we have some indications, but not very good, and this is sustained drug-free remission. Let me not give you all the data, but I think this is probably the sort of best data that the B cells are really different between the patients who have a converter versus who is non-converter. This is all association. It is not causative, so the problem of it, but I think if you say what can be causative, and I don't have that slide. We have some, sorry, I had too many slides. We have some prospective patients, and then you see really that the ACPA positive B cells between the converters and the non-converters have a different phenotype. And that is not proving causality, of course, but I think it's a very strong indication over time. So what we really want to do is to kill those ACPA positive B cells and then show that the patients develop RA at a lower rate than the patients where we do not kill ACPA positive B cells. And the good thing about, from a clinical point of view, we are able to identify these patients. And we just published in the Lancet about half a year ago that we did a trial like that. That was not focused on ACPA, but so we are able to do the trial. We have some indications that we can prevent RA by treating in that phase. And now the hypothesis is we really would like to interfere on the ACPA-specific B cells there. But it is too early days. I hope that Gordon will organize this meeting over and over again because the place is so fantastically beautiful, and then I hope I can, maybe in 2 years' time, I can give a talk again. Okay, without further ado, then it is my great pleasure to introduce my friend René Toes, who will give the talk after me.